The enemies we fight against do not slow down. Cancer is relentless. Diabetes is relentless. Time is relentless. So we are relentless. We lose sleep at night dreaming of solutions for wearable technologies, remote monitoring, advancements, innovations, any weapon to win the fight. We are the men and women of Ochsner, and we are relentless. We're doctors and nurses and dreamers and healers, but above all, fighters. Yes, fighters.
Keep working it.
Because when it comes to your health, good is never good enough. So we do not slow down. Ochsner, innovating healthcare.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about compression of the cervical spinal cord. Our guest is orthopedic spine surgeon, Dr. Paul Celestre. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200 and by email too. Just email your questions to us at hhquestions@wlae.com. Well, Dr. Paul Celestre is a board-certified orthopedic spine surgeon. He received his medical degree at the University of California in San Diego. He completed his internship and residency in orthopedic surgery at the University of California in Los Angeles. He finished his fellowship training in spine surgery at the Norton Leatherman Spine Center in Louisville, Kentucky. And it is our pleasure to welcome back to the program Dr. Paul Celestre. Good to have you back, Doc.
Thanks, Tom.
Yeah, some news since our last visit. You have your one daughter, right?
Mm-hmm.
And another
Yes,
one
we're
on the way,
expecting
right?
another one in March, absolutely.
All right, and we don't know.
No.
Wife wants to be surprised.
Big surprise.
All right, and a surprise for baby sister too, right?
Yeah, she just has a baby carrier to carry around her little baby now, so she's
Very
working on
good.
that.
Well, congratulations
Thank
to you and your family. The last time you were here, Doc, we were talking about adult scoliosis. Tonight's topic is cervical spinal cord compression.
Mm-hmm.
So what is cervical spinal cord compression?
Sure, so cervical means neck, right? So we have cervical spinal cord, we have a cervix, or women have a cervix in their uterus. It's just a Latin term for neck. Cervical spinal cord compression, when it becomes symptomatic, in medical terms we refer to it as cervical myelopathy, or spinal cord dysfunction that presents with different clinical symptoms.
Okay. What are the symptoms of cervical spinal cord compression?
Sure. The number one thing patients complain about is difficulty with small things. Very commonly, patients will say, you know, I feel like the holes of my shirt got smaller in the laundry. The buttons just don't go in as easily. Or they have difficulty with coins or keys. Or all of a sudden they notice that their handwriting, which once was very neat, is no longer neat.
And so could these be the symptoms of something else other than this?
Although they certainly could be. If someone has those specific symptoms, as well as things like numbness in their hands, weakness of grip, difficulty opening jars.
Tingling, perhaps?
Yes, absolutely tingling. They should be seen by their primary care doctor, if not a spine surgeon, to be evaluated for cervical myelopathy because it's such an insidious problem.
Let's back up half a step and just talk about the spinal cord and the role it plays in the body.
Sure, so if you think about the spinal cord as being a conduit to transmit messages from your brain to your extremities and from your extremities to your brain. And when it's compressed, when you have this ongoing compression of your spinal cord, it begins to not work properly. And that's how you develop these symptoms.
What causes cervical spinal cord compression?
There are a lot of different causes. The most common cause is cervical spondylosis, or arthritis of the cervical spine. All of our discs wear out with time. As we get older, it is the natural history of our spine to begin to develop arthritis, drying out of the discs. For some of the people, that drying out of the discs and the bulging of the discs can lead to spinal cord compression and cervical myelopathy.
Does it have anything to do with posture?
Although it can, in general, it is not related to your posture.
Okay. And with that, I'll sit up straight, knowing that I might not actually be helping, but it's probably good for me anyway.
Fair enough.
What about traumatic injuries? And what role does that play?
Absolutely. So the CT scan that they're showing is from a patient who was involved when the tornado hit the trailer park in Convent, Louisiana, about 2 years ago. And this patient had a traumatic injury to her cervical spine and presented with weakness in their hands, as well as numbness and tingling, and eventually underwent surgery for that problem.
Talking about trauma, are athletes at greater risk of developing this condition?
I guess people who play contact sports, such as football, hockey, lacrosse, are certainly at greater risk of cervical spine injury. I think also very important is to realize that cheerleading is a contact sport, and diving as well. So there are many cheerleaders that have spine injuries. That is something that we're trained to evaluate, and on-field doctors, including Austrian on-field doctors, can evaluate you for this.
Soccer can be, especially in the area of headers.
Absolutely.
And that sort of thing.
Absolutely.
Yeah. Are there any other conditions that could cause this compression?
Sure. Although they are more unusual, they are certainly not rare. Things like tumors that have metastasized to the bones, or infections affecting the discs. People who have a history of being immunocompromised, history of a transplant, certainly are at higher risk for these more unusual infections that can cause this problem.
Our guest is Dr. Paul Celestre, and tonight we're talking about spinal cord compression. What about neck pain? What role does neck pain play in all of this?
Neck pain is very common, but neck pain is not really related to cervical myelopathy, to symptomatic cervical spinal cord dysfunction. Although you can certainly develop neck pain from arthritis, it can come from a lot of other things too: muscle spasms, stress, fatigue. So although neck pain may be associated with cervical arthritis, it is not a symptom of symptomatic cervical spinal cord dysfunction.
Okay. What about bulging discs in the neck? And let's go back again. Exactly what is a bulging disc?
Sure.
And how does that factor in?
So the discs are between our vertebral bones in our neck, and they act as a shock absorber and also as something that allows motion between the discs. So we have motion of our neck in terms of flexion, extension, rotation. The discs themselves are comprised of an outer layer, an annulus, that is firm, and a soft layer, an inner layer, the nucleus. And when we talk about a herniated disc, what we really mean is that that nucleus has moved out of where it's supposed to be and is now pressing on either a nerve root, which can cause radiculopathy, pain that travels down the arm, or myelopathy if it's compressing on the spinal cord, this dysfunction of the spinal cord.
So when a patient comes to see you, I guess normally would this be detected by a primary care physician?
It is very commonly detected by a primary care physician, especially when patients have a component of radiculopathy, of pain traveling down the arm. Primary care doctors are excellent at evaluating patients and then referring them to me if appropriate.
So a patient comes to see you, the first thing you're probably going to ask for is a history.
Absolutely.
Even if you've already shared that with your primary care physician, it's going to start with you again, right?
There is no question that I'm going to ask you a lot of questions, and you may be repeating yourself that you've told someone else, but I like to hear it from you directly. I want to hear your history. Taking history is one of the most important things that any physician can do. And the next most important thing is a physical examination. And that comprises a number of different things: strength and sensation testing, watching a patient walk, so critical to evaluating patients for spinal cord problems, and a reflex examination as well.
Okay. What kind of x-rays or other imaging should a person expect from a visit to you?
Certainly coming to see me, we're going to order x-rays of your neck to evaluate what's going on. X-rays paint such an accurate picture of what your spine looks like, how much arthritis do you have, what is the alignment of your spine. So you mentioned posture, but I guess posture and the alignment of your spine are related but not necessarily the same thing. X-rays can also tell us about more unusual things like tumor, or obviously in the setting of a trauma. if we're concerned about myelopathy, if we're concerned about compression of your cervical spinal cord, we're also going to order an MRI.
In this next image, I remember, spoiler alert here, this is from Thelma and Louise, so if you haven't watched the movie, it doesn't end well, depending on, I guess, how you look at it, but there's Thelma and Louise going off the cliff. What happens if a problem like this is not treated?
Sure. So to know how to treat any problem, you have to understand the natural history, meaning what happens if you don't treat it. And the best analogy that I was ever given about cervical myelopathy was from one of my mentors in residency, who told me that patients with cervical myelopathy are like Thelma and Louise driving towards the cliff. The only difference is that they don't know how far the cliff is. And when I say the cliff, what I mean is a new neurological degeneration. So what happens in cervical myelopathy is that someone may early on have the symptoms that we discussed: numbness and tingling, difficulty with buttons and coins and keys. But because they begin to have further compression on their spinal cord, perhaps they have a fall and hit their head, now they have a neurological decline. Now they have weakness in their hands, increasing gait abnormalities, and then unfortunately they have another fall that makes those problems even worse. Cervical myelopathy that is left untreated has a stepwise degeneration, meaning that it gets worse rapidly and then has a stable plateau period, that driving along the cliff. So we don't know how far that drive is. And unlike an example of, unlike something like hip arthritis, which tends to get gradually worse over time, cervical myelopathy gets worse all of a sudden. And so that's why we're aggressive about treating it early.
So something that may be difficult to do may become impossible to do and may not be able to be reversed?
I guess the operation may technically not change in its difficulty, but the outcome of the operation will change if you allow patients to have progressive neurological declines.
Okay. In a moment, we're going to be taking your questions and talking about treatment options. Here's our phone number, 504-866-3200. That's 504-866-3200. You can call us with your questions right now, or if you don't want to call us, you can send us questions by email. Our address is hhquestions@wlae.com, and we're monitoring that email address, and we'd be happy to take your questions that way. So let's talk about treatment options. Doctor, what are some of them available for cervical spinal cord compression?
Sure. So going back to the driving towards a cliff analogy, the treatment of cervical myelopathy, the primary goal is to prevent the problem from getting worse. The only effective way in 2017 that we have to do that is with surgery. There is no effective treatment option. So physical therapy, medicines, injections, things that we very commonly do for other spine problems, unfortunately do not help in the treatment of cervical spinal cord compression. And that's why we talk about surgery early on when this problem is diagnosed.
So surveillance really isn't even an option either if you've been diagnosed.
Only in patients with minimal symptoms, with no changes to their spinal cord detectable on MRI, would I even consider an option for treatment. And some surgeons don't even consider an option for treatment for any type of cervical myelopathy. That's a discussion that has to be had on a patient-to-patient basis. Certainly other things like extensive comorbidities, people who are very medically ill, who may not even be a candidate for surgery, then perhaps observation would be reasonable. But really in any patient, given the extremely unfavorable natural history of this problem, surgery is something that any surgeon is going to discuss.
Okay. What is the goal of surgery? Is that different, and is that different for each patient?
Sure. Very commonly we think about orthopedic surgeons as taking a problem and making it better. For example, a broken bone, arthritis of the hip, carpal tunnel syndrome.
Back pain, severe back pain.
Exactly. Cervical spinal cord compression is different. The main goal of surgery is to prevent the problem from getting worse because we know that it will. Now, many patients say, well, is my grip going to get stronger? Is my balance going to get better? And the outcome, the improvement after surgery is unknown. I generally counsel patients that if they've had their symptoms for a short period of time, they definitely have a chance of getting better. And don't take it the wrong way. I've seen people who are wheelchair bound because of cervical myelopathy, because of their weakness and balance problems, regain the ability to walk with obviously extensive physical therapy. But the number one goal of surgery, and I cannot stress this enough, is to prevent the problem from getting worse.
That sounds like a difficult sell, because if I'm in severe back pain, right, and you would say to me, I'm 90% sure I can make that back pain go away. Sign me up tomorrow.
Okay.
Right? Whereas I can promise you, no guarantee with any surgery, right?
Sure.
But the odds are your problem won't get worse and you have it already. I'm not suggesting people not have this, but it just sounds like it's tougher for people to make that leap.
You know, honestly, when you sit down with someone and you explain their MRI to them, you explain their physical examination findings are abnormal, and you talk about how this disease has an unfavorable natural history, most patients actually understand pretty clearly what's going on, and they understand that treatment is required.
If not, you show them the Thelma and Louise car and that analogy, and then that I'm sure helpful. Let's talk about fusions as an option, and let's start with what is a fusion.
Sure.
And that fusion is a term that scares a lot of people, I know.
Absolutely. So when you talk about fusing anything, you can fuse any joint. That is basically creating a climate in the body that makes a joint want to go away. So in the spine, what we do is we remove the cartilage from the joints and lay bone graft down to create the impression to the body, to trick the body into knitting two bones together that otherwise would not be knitted together. So that is a fusion. And fusions have been done for over 100 years. Originally, they were pioneered to treat tuberculosis of the spine. But now we use them for all sorts of different things. The goal of a fusion is to stop motion of the spine. Fusions also allow us to be very aggressive about our decompression. Like I mentioned, this is a problem of mechanical compression. And so during a fusion of the spine, we can decompress it very thoroughly, more thoroughly than we could if we weren't fusing it. And instrument the spine. So place, in this patient, she had an occipital plate, so a plate placed onto the skull and screws that came down into her neck.
There it is again, doctor.
Yes, to treat very severe rheumatoid arthritis of the spine. And this patient had very profound cervical myelopathy and could barely use her hands.
Are there any surgical options that would not include fusion?
There are. There are limited surgical options for myelopathy, meaning compression of the cervical spinal cord. Probably the most common one is cervical disc replacement, and this is a X-ray of a medical student who had a cervical disc replacement after they were involved in a car accident. Another option is something called a laminoplasty, which is a posterior-based surgery, a surgery through the back of the neck to create more room for the spinal canal. Many patients are afraid of fusions because they know someone or they've heard anecdotally that it leads to more surgery down the line. And I certainly understand that, and I'm happy to talk to anybody. But I generally present a patient with what treatment options are appropriate for them, and then help guide them to making the right decision. And the right decision is different for each patient. But avoiding a fusion is not necessarily a good thing.
In the more traditional surgery that you have described tonight, where is the incision? How long? Take us into a surgery. How long does the surgery last? That's those sorts of things.
Sure. There are two different approaches to treating cervical spinal cord compression. Either surgery through the front of the neck, which is typically made via a transverse incision, or a posterior through the back of the neck incision made with a longitudinal incision in the midline of the neck. There are different reasons to do those different surgeries. If the disease is fairly limited, if the compression on the spinal cord is fairly limited, certainly an anterior surgery involves less morbidity and less recovery time. With more severe problems, especially over longer segments, multiple discs, multiple problems, we do a surgery through the back of the neck to address that. Sometimes when we have to fuse to the skull, we have to include obviously a posterior-based surgery. And there are other times where people with very, very severe disease, I saw a patient today who has very severe disease, they were planning a surgery through both the front and the back of the neck in a delayed fashion. So the aggressiveness of the surgery depends on how bad the problem is. If it's limited to a single disc, then a single disc can be removed. It could potentially even be a replacement. If it's all throughout your spinal cord and you can't walk, then you're going to have to be more aggressive.
Length of the surgery going to be determined by the severity of the disease?
Absolutely. A straightforward cervical disc replacement in an otherwise healthy person takes an hour. And extensive posterior surgery can take, multiple hours. So it just really depends on the problem.
Talk to us about the recovery time, the risks involved with surgery, those sorts of things.
Sure. So patients who have a surgery, especially through the front of the neck, often go home the next day or perhaps 2 days after surgery. And that involves both anterior fusions and disc replacements. People having surgery through the back of the neck tend to have a little bit more pain. By the nature of the problem, they have a little bit worse problem, so they're going to stay a little bit longer. I divide the recovery time up into a few different things. So first, just being in the hospital, and then, the first few weeks after surgery, letting your wound heal, working with physical therapy either at home or in a rehabilitation or nursing facility. And then sort of the longer term, typically, I wait for up to a year until I tell a patient, I don't think your symptoms are going to change a lot. So, if you're still feeling pretty bad, you're still having significant ongoing myelopathy at 6 weeks from surgery, to me that doesn't mean there's a treatment failure. It means we have to be a little bit more patient.
Okay. How often will you have to go back in based on patient feedback or continued exams and redo the surgery or add to what's been done already, something perhaps we didn't see the first one?
That's a great question. With contemporary radiology imaging techniques, so X-rays, CTs, MRI, we're very good at identifying where the problem is. Certainly there is a risk of needing future surgery after you've had a spine surgery, and particularly anterior fusions of the neck. Now, on the other hand, that is one of the best operations that we can offer to anyone for anything. And patients who have had that very commonly feel better very quickly. On the other hand, the risk of needing future surgery is a cumulative problem, so it gets more and more over time. So if you have a surgery when you're 25, at some point in your life it's very likely that you'll need a future surgery. Now that is why disc replacements were invented, to help decrease that risk of future surgery. Now, we still don't have the long-term observational data to tell people exactly what their risk is. With replacements, it seems much lower. On the other hand, if you have very severe arthritis of your neck in your 20s, you may not even be a candidate for a cervical disc replacement. So this isn't to say that everybody who's young gets a disc replacement and everybody who's older gets a fusion. You really have to treat your pathology, you have to treat the patient and their pathology, on a per patient basis, not as this is what I do for this patient. You have to really sort of assess everything and take a look and treat the patient appropriately.
Okay, our guest is Dr. Paul Celestre. Tonight we're talking about cervical spinal cord compression and treatment options. So what is your hope that people will take away, our viewers, tonight from watching this program?
The most important thing to remember is that compression of the cervical spinal cord isn't painful. The number one reason people go and see their doctor is because of pain. Pain somewhere. Pain here, pain traveling down the arm, pain traveling the leg, pain in the low back. That's the number one reason anybody sees any doctor. But this is a problem that is not painful. The symptoms of this problem are difficulty with buttons and coins and keys, something that many people say, I've had this for years, and I just kind of thought that that's how it was. People will create an excuse for themselves, not in a bad way, but they'll just say, I guess I'm just clumsy now, and that's
or getting a little older.
Exactly.
Yeah, that's right.
Oh, my handwriting isn't what it used to be, but I'm 60, and that may be normal, but it may not be normal. And then the last thing, like we discussed, is that surgery is done to prevent problems from getting worse. We know the natural history of this disease. We know it gets worse over time. And the number one goal of surgery is to prevent neurological decline.
You mentioned in most of the cases it's a wear and tear disease, right? There are some examples of where that's not the case, exceptions, trauma, tumors, those sorts of things. Good to have a baseline. And at what age would this start to set in under normal conditions?
Honestly, we see it in people in their 20s and in people in their 80s. So there isn't really a specific age range. It very uncommonly affects children, except in the setting of trauma, tumor, or infection, or something more unusual. I don't think that everybody needs to have a baseline X-ray or MRI of their neck. I don't think that that's reasonable or practical. It's just something that people need to be aware of. And very commonly, the beginning complaints, the early complaints, like we discussed, are sort of, well, it's not that bad. And the number one thing is that it's not painful, and so people tend to overlook things that aren't painful.
Finally, I know there's some people you'd like to acknowledge tonight before we get to our viewer calls and emails.
Oh, absolutely. Well, I think my partner, Dr. Clevis, is someone that I operate with almost every day and is just a wonderful resource. And the entire neurosurgery department at Ochsner does a great job. A lot of our advanced practice, our PAs and NPs, so Sarah and Stacy and Melanie, all are fantastic. April, I feel, is the cowboy herding the cats or I guess the cowgirl herding the cats in my practice. Erin, Sarah's medical assistant, and of course, my patients. It's my greatest pleasure to take care of them and be a part of their lives.
So nice of you to recognize your teammates there at the office. We're ready to take your calls now and emails with Dr. Paul Celestre. That number again is 504-866-3200. That's 504-866-3200. Or you can email questions to us at that address, hhquestions@wlae.com. We'll have that on the bottom of our screen when we come back with your questions in a moment. You're watching Hello Health on WLAE.
I love taking care of my mom. It wasn't easy at first. She learned how to better communicate her needs.
And you learned how to not ignore yours.
I discovered how to make healthier meals.
And I discovered how much I enjoyed them.
Becoming a caregiver is a learning experience for everyone. Find articles, tips, and tools from experts and others who have been in your place. The Caregiving Resource Center at aarp.org/caregiving.
And welcome back to Hello Health. I'm Tom Bagwell. Good to have you with us tonight. We're talking about spinal issues and treatment options with the orthopedic spine surgeon Paul Celestre. You've been with the Ochsner team now for about 3 years, and let's get to your questions. Let's start on line one. Dylan is calling us from Marrero this evening. Dylan, welcome. You're our first caller on tonight's Hello Health.
How you doing, Doctor? I'm trying to find out. I had a C3-4 fusion back in 2005. I'm trying to figure out, it's collapsing. I just did an MRI. And it's starting to collapse and what have you. So what they trying to do, and I'm starting to have the electrical pains down my arm and what have you. And I'm trying to find out, they want to deaden the nerves where it's collapsing, I guess, and then if that works, then they want to burn it. I just want to hear your input on that.
Sure. So perhaps they were talking about doing an epidural steroid injection or something called like a nerve ablation. So they're two different things. Now, I guess I would say if you're only having pain traveling down the arm, then that may be a reasonable treatment. On the other hand, if you're beginning to develop the symptoms like I discussed, things like difficulty with buttons or coins or keys, then certainly, perhaps being evaluated by a surgeon may be more appropriate. I think that it's very reasonable to have epidurals in the setting of pain only, but once you begin to develop things like weakness or difficulty, with your handwriting, you should really be seen by a surgeon and we could look at it together.
Dylan, thank you so much for your question tonight. When you talk about handwriting, so my handwriting is horrible. If you ask anyone in my office, they always have to say, no, what does that say? And they always do it gently and politely and professionally. But so I'm not sure what my handwriting, that it was ever good. The joke is I should have been a doctor, although I'm not nearly smart enough as you and many of our guests.
I don't know about that.
But so I don't really have a baseline on my, so are you talking about getting tired with handwriting, the sloppiness of handwriting? What should I be looking for, or should a patient be looking for?
So can you read your own handwriting?
Sometimes.
Okay, well, perhaps using handwriting changes then isn't most appropriate for you. But I think as someone who wears a button-up shirt, particularly the collar buttons, the smaller buttons,
right.
If you began to develop myelopathy, that's probably the first thing that you would notice. Very commonly, people who are a little bit older were taught penmanship. I was never taught penmanship, and I'm also a physician, so my handwriting probably isn't the greatest. But if you develop myelopathy and you had poor handwriting already, it would probably become completely illegible. Or your signature was changed. So something that you actually can do neatly and repetitively, you would notice that you can no longer do that, and it's very sloppy.
Even slowing it down.
Yeah, it doesn't really matter how fast you go.
Okay, that's a great point. Here we have an email question, Doctor. What type of infections can cause this type of spinal compression?
Sure. So there are a few different types of infections that we consider in patients with cervical myelopathy. So discitis is an infection of the disc, and that can happen to anybody. I've seen it in people who have had, a dental cleaning. So having your teeth cleaned showers your body with bacteria. That's why we give patients with joint replacements antibiotics before they have a dental cleaning. There isn't a reason for everybody to have that, but you can see it. Other more unusual infections, things like tuberculosis, can cause compression of the spinal cord because the tuberculosis bacteria preferentially likes to go to the vertebral bodies. So, there are things like staph and strep, things like tuberculosis. In transplant patients, I've seen fungal infections of the spine begin to cause spinal cord compression. So it can really be anything. And in someone who presents to the hospital with neck pain, difficulty walking, numbness and tingling in their hands, that's very high up on our differential diagnosis of what their problem could be.
Our phone number tonight is 504-866-3200. That's 866-3200. We do have lines open for your calls and questions tonight. Doctor, here's another email. I'm a 32-year-old female and I do a lot of high-impact workouts. Should I avoid this type of exercise?
Well, I guess I would say if high-intensity workouts aren't dangerous in themselves, as someone who treats patients with ruptured disc in their low back on a repetitive basis, I do caution people about things like deadlifts and power cleans and things that really involve a lot of lifting and jerking. I don't think for a young, otherwise healthy patient that it's dangerous, but certainly if they've developed symptoms of pain traveling down their arms, pain traveling down their legs, that would be something that we are concerned about.
Okay, thank you for that question. Again, 504-866-3200 is our number for your questions tonight with Dr. Paul Celestre. Here's another email question. Are there more options for treatment of lumbar versus cervical spine problems? I've been diagnosed by X-ray with moderate disc height loss noted throughout the lumbar spine, lower lumbar face, facet, arthropathy noted. And this is a question from, is it from Jeff? The question is from Jeff? It looks like maybe so. Yes.
I guess it depends. So, for someone who has lumbar degenerative discs and lumbar facet disease, you aren't at risk for cervical spinal cord compression just by nature of your problem. And there are a lot of options for treatment of lumbar degenerative discs and lumbar facets. Conservative treatment, anti-inflammatories, physical therapy. I recommend dry needling a lot, which is a trigger point release using dry needling. Some people think it's similar to acupuncture in the sense that it uses needles, but it's a little bit more Western medicine than Eastern medicine.
And what does that involve?
So it involves placing a needle into a trigger spot that is bothering you and getting it to release, and it's very, very effective. A lot of athletes do it. Things like cupping that became very popular after the Olympics with Michael Phelps, and you could see the marks on his back from that. Other things like the nerve ablations, nerve burnings, epidural injections, and potentially surgery depending on what it looked like. So there are a myriad of options, and what's right for you, is a discussion I'd be happy to have with you.
All right. Our phone number is 504-866-3200. That's 504-866-3200. We do have phone lines open. Our guest tonight is Dr. Paul Celestre. We have Yvonne on the line calling us this evening. You're on line 1. Yvonne, welcome. You're on with Dr. Celestre on Hello Health.
Hello, and thank you so much for your being there. I have a question about spinal stenosis. Is anything can be done about that, and if so, what?
And just to clarify, ma'am, do you mean spinal stenosis in the low back or spinal stenosis in the neck?
The lower back.
Yes, so there are a lot of treatment options for spinal stenosis in the low back.
And let's talk about spinal stenosis first.
Sure.
To make sure everybody understands what we're talking about.
So stenosis means narrowing. Narrowing of the lumbar spinal canal in the low back can lead to symptoms that we call neurogenic claudication. People with neurogenic claudication typically have aching, burning, or numbness in their legs that is worse when they're walking and relieved by either sitting down or leaning forwards. So very commonly when I see a patient who I suspect has lumbar spinal stenosis, I say, does it feel better when you use a shopping cart? And almost every patient says, yes, I really lean forwards on my shopping cart, and that makes all my pain go away. The treatment options for lumbar spinal stenosis in the beginning are the things we discussed previously, so medicines, physical therapy, and epidural injections. There is some medical evidence to suggest that patients, in fact, shouldn't even have an epidural injection for spinal stenosis. They should just go right to surgical decompression. I'm a little bit more conservative. When I treat patients with stenosis, at least in the beginning, we try everything we can to avoid surgery. And that's something that I was taught and something I believe. But, there's a myriad of treatment options for spinal stenosis. On the other hand, it really depends on where the stenosis is and what's causing it. If it's a bulging disc, of course that disc can be removed. If it's arthritis, if there's a slipped vertebra, it may require a fusion. And so every patient is a little bit different, but there are a lot of treatment options for lumbar spinal stenosis. Many of them are conservative.
For someone who has a lot of back pain, but more of it laying down. So you would think, get off your back, get off your feet, I'm going to feel better. Mm-hmm. But sometimes it's worse. This is someone I know very well. Mm-hmm. While they're sleeping, it's worse of a problem, and laying down, it's worse of a problem.
Sure. So that is a time where the x-rays are really, really important. X-rays show the alignment of your spine. So for anybody who's had an MRI, they know that in general you're laying down for your MRI. And I guess as opposed to this patient, most people's pain is better when they're laying down. On the other hand, you can get x-rays with someone standing up and then laying down to see if the alignment of their spine is changing. And based on that story, I would guess that it is. So very commonly when someone comes to see me, we get flexion and extension x-rays, asking the patient to lean forwards as much as possible and asking them to lean back as much as possible to see if there's any shifts in the alignment of their spine. An MRI may or may not detect even fairly significant slips of the vertebra, spondylolisthesis, in the absence of an x-ray. So we like to get x-rays to evaluate the alignment of your spine when you're standing because positioning makes a big difference.
Let's go back to our phone lines. Emily is calling us on line 2, calling us from Gray, Louisiana, I believe. Is that right, Emily? Welcome. You're on with Dr. Celestre.
Yeah, hi. Dr. Celestre.
Hi.
I have a question about the myelopathy.
Mm-hmm.
Hello?
Yes, go right ahead.
Go right ahead, Emily.
I'm sorry. Okay. Do you get when you said the symptoms for myelopathy in the hands, and my handwriting has become it's bad now. I wasn't like that. I used to have really pretty handwriting, and I'll get cramping in my fingers that I don't know why it's doing that. And I had to ask you, was there any kind of exercise you can do to make it better?
Unfortunately not. So myelopathy and compression of the spinal cord doesn't respond well to exercises. Now, don't get me wrong, there's definitely a component of both physical and occupational therapy that is part of the treatment, But if you've developed symptoms such as difficulty with your handwriting, where it used to be neat, now it's very sloppy, cramping in the hands, difficulty with buttons, balance problems, you should definitely be seen and evaluated for that.
Emily, thank you so much for your question and for your call tonight. 504-866-3200 is our number, and we do have phone lines open. Let's go to Ashley calling us from New Orleans this evening. Ashley, you're on 3 and you're on Hello Health.
Hi, how are you doing? I was calling, I wanted interested to see if you were familiar with the laminoplasty procedure.
Yeah, absolutely. So a laminoplasty procedure is a non-fusion option for posterior decompression of the spine. Laminoplasty, to me, is appropriate for select patients. So number one, they have to have a either neutral or lordotic alignment of their spine. So someone who comes in kyphosis, leaning forwards, is not a good candidate for laminoplasty. Number two, most patients who are a good candidate for laminoplasty don't have a lot of neck pain. And in fact, I personally believe that neck pain, significant neck pain, is a contraindication to laminoplasty, because although a laminoplasty is really good at decompressing your spinal cord, it does tend to leave patients with a little bit of neck pain. There are other patients who are particularly appropriate for laminoplasty, particularly patients of either Japanese or Korean descent who have a problem called ossification of the posterior longitudinal ligament. And there are also people in Louisiana that have this problem from all sorts of different genetic backgrounds. It's just people of Japanese or Korean descent are particularly prone to this. Laminoplasty is a 100% reasonable option and treatment for cervical myelopathy. It just has to be in the right patient.
Thank you so much, Ashley, for your question. So laminoplasty is what? What are you doing?
So a laminoplasty is a posterior-based procedure that creates more space for the spinal canal. So what the spinal canal is a ring. The posterior, the back part of the spinal canal is called the lamina. And so a laminoplasty involves making 2 cuts in the lamina and then basically making the spinal canal surgically larger and then holding that osteotomy open with small plates and screws. So it's an option that doesn't involve a fusion, but does allow a thorough decompression of the spinal cord.
Our phone number is 504-866-3200. That's 866-3200. You can also send us questions by email, and many of you have already. hhquestions@wlae.com. You see that there at the bottom of your screen. Let's go to line 1. Brad is calling us tonight from Duckworth, Mississippi. Brad, good to have you with us. Thanks for calling.
Oh, thank you so much.
Go right ahead with your question for Dr. Celestre.
Good evening.
Okay, I fractured C2 vertebrae about 2 years ago, and it's still fractured. And I'm having pain going up the back of my neck over the top of my head.
Mm-hmm.
And they didn't do surgery on it. They said it didn't heal and it won't do anything. The very back of the vertebrae is broken in 2 places. Is there anything I can do for that pain besides taking, medication?
Well, certainly a non-union of the cervical spine. When we have a fracture of any bone, the body's desire is to heal it. Orthopedic surgeons and neurosurgeons can do things to increase the rate of the healing. For example, the most basic is putting on a cast. Immobilizing a limb helps the bones to heal. That is very commonly the reason that we put either plates and screws and rods in people's necks or backs in the setting of a fracture. In your situation, if the fracture hasn't healed 2 years from the injury, it is very unlikely to heal on its own. On the other hand, I'd be happy to see you and take a look at your CT scans, your x-rays, and figure out either A, why this fracture didn't heal, and B, what can be done about it, because your symptoms are very, very consistent with a fracture that hasn't healed. So yes, I think you probably do have some options besides just pain medicine.
Brad, thank you so much for your question, and we're going to be providing a special number just for viewers of this program to make an appointment with Dr. Celestre or any of the guests here on Hello Health. Brad, thanks again. Let's go to line 2. Rita is calling us, it looks like, from New Orleans. Rita, you're on line 2, and you're on Hello Health with Dr. Paul Celestre.
Thank you. My question is, I have been having really severe back pain for about 10 years. I've tried everything, the shots and physical therapy, and I have a spondylolisthesis 1 grade, and really spinal stenosis, and I think a little bit of a bulging disc, but not much. But in March, I had terrible, like, pains in the back of my hamstrings and my buttocks, and it's excruciating. Is there anything, I mean, could the spondylolisthesis cause that, and do I need surgery? Because I have seen the surgeon, and that's my question.
Sure. So spondylolisthesis, as you described, is a slipped vertebra. It is one of the most common reasons that people over the age of about 40 develop sciatica. So the pain that you were describing, pain in the buttocks, pain traveling into the hamstrings, to me is the most common presentation of sciatica. All of us are taught that sciatica is pain that shoots all the way down to your foot, but more commonly it's pain in your buttocks. In the setting of someone who has a spondylolisthesis, low back pain, sciatica pain that has been refractory to conservative treatment, surgical intervention, usually in the form of a fusion, given your spondylolisthesis and slipped vertebra, has been shown in multiple studies to be extremely effective at treating your pain. I'd be happy to talk to you about that.
Rita, thank you so much for your call and question tonight. Let's go to line 3. Barbara is next, calling us from Metairie. Barbara, you're on Hello Health with Dr. Celestre.
Hello, Dr. Celestre.
Good evening.
I have a question for my husband who suffers with severe neck pain, and he has very limited neck mobility, and was told that he has bone spurs.
Mm-hmm.
So is there any particular surgery for that?
I guess what I would say is it really depends on what the X-ray, the MRI, the CT scan looks like. So we commonly refer to bone spurs in the neck. What we're really talking about in medical terms are osteophytes. Osteophytes are the hallmark of arthritis. They're the body attempting to stabilize a joint that has become degenerative or arthritic. On the other hand, it is a very, very reasonable thing to treat patients like your husband who have just isolated arthritis conservatively. But I would say that if he has failed to find relief, he should at least come talk to a surgeon. Like I mentioned previously, my job is to try to avoid surgery for you. And I will do everything I possibly can in terms of conservative treatment before we talk about surgery, unless it's appropriate to talk about surgery immediately in the setting of cervical myelopathy. So I'd be happy to talk to your husband about what the options are for treatment.
And just to go back and recap what we've been talking about all night, when we're talking about the myelopathy, thank you very much. You think I know it now, 55 minutes into the program. There really is no option other than surgery with that particular, tonight's particular condition.
In someone presenting with myelopathy, yes. Now, very commonly, people with bone spurs in their neck just have cervical arthritis, and they're not having spinal cord compression, they're not having nerve root compression, and those patients we treat conservatively. The number one thing I tell people when people come to see me, when my friends who are physicians come to see me, is let's get you physical therapy, get you started on anti-inflammatory medicine, and get you started on a home traction machine that you can buy on Amazon for $18. So, that is something that, I consider and I recommend to a lot of people, and I think there are a lot of surgeons out there who have home cervical traction machines or ones in their office because of me.
All right, let's go to line 1. Christine is next, calling us from Metairie. Christine, welcome. You're on Hello Health.
Hi.
Go right ahead, Christine.
Oh, okay, so I have the spondylolisthesis, and I was in a car accident today. I was rear-ended. Not too bad, but is there anything I should have any precautions of?
And just to clarify, did you have spondylolisthesis before the car accident?
Yes.
You did? Okay, and is your pain worse since the car accident?
Yes.
Well, maybe we should see you.
Oh, no.
Well, look, I'm not saying that it's terrible, but in someone with a known problem, maybe it's time for some treatment, like some physical therapy, anti-inflammatory medicines, or even a brace.
But just for her to be on the safe side, she should see somebody.
Absolutely, especially if your pain is worse after a motor vehicle accident.
All right. Christine, I hope that's helpful. Thank you for calling tonight. 504-866-3200. Time is winding down, but we do have time for another question or two. Let's go to Sandy, who's been holding patiently on line 2. Sandy calling us from New Orleans. Sandy, you're on with Dr. Paul Celestre.
Hi.
Hi.
Good evening.
Am I on the air?
You are on with Dr. Paul Celestre. Go right ahead with your question, please.
Okay, my question is, I was involved in an automobile accident 2 years ago, and I had chronic, I had a life-altering well, I had a surgery in between. I had it's two herniated discs that they discovered on the MRI, and it stopped. I had the surgery for another issue, and then it started again 3 months into my rehabilitation. But it came back worse than what it was when I first had the accident, and I have had chronic sciatica for 11 months now. I've had the deep tissue massage. I've had dry needling. I've gone through all therapies. I'm on pain meds right now, but I've seen 2 neurologists, and they both suggested that I have surgery. So I have the surgery set up for, I think it's a discotomy.
A discectomy, yes.
On the 25th. Is it necessary? I've done everything that I could. Is this at the bottom of the rung where I have to go ahead and have the surgery?
Well, I guess I would say that, it's hard to know without, specifically examining you, looking at your x-rays, looking at your films. But, what I counsel patients is that if you've had symptoms that have been present despite all your best attempts to make them better, so anti-inflammatory medicines, physical therapy, epidural injections, and they've been bothering you for 11 months. Moreover, if they're stopping you from doing the things you either need to do, like, we all need to clean our house, make food, we call those activities of daily living, or your activities of recreation. If you're avoiding and doing things with your family or friends because you're worried that your back is going to hurt you or your leg is going to hurt you, then I think absolutely surgery is a reasonable plan. But surgery is reasonable when you've tried to avoid it, you've done everything you possibly can.
Thank you so much, Sandy, for your question tonight. Our guest tonight is Dr. Paul Celestre, an orthopedic spine surgeon. And tonight we're talking about the back and the spine. And let's go to another email question. This is from Charles, Doctor. Explain the difference, if you would, between a neurosurgeon and an orthopedic surgeon.
Sure. So both neurosurgeons and orthopedic surgeons operate on the spine. Orthopedic surgeons also commonly treat other fractures of the hip, fractures of the knee, broken arms, things along those lines. Most orthopedic spine surgeons have done an additional year of spine training, so operating specifically on the spine only. Many neurosurgeons are exposed to extensive amount of spine surgery during their training, and so don't do an additional year, and that's very, very reasonable. We tend to approach problems pretty much the same way. I would say 15 years ago, there was a lot of divergence between the fields. But as our societies have become more collaborative, specifically things like the Scoliosis Research Society, where there's a lot of collaboration between orthopedic surgeons and neurosurgeons where we work together, I don't know if you're going to get a whole lot of difference between the two. I think orthopedic surgeons tend to be a little bit more focused on bones and bone biology, and neurosurgeons tend to be a little bit more focused on the spinal cord. But at the end of the day, if you're talking about the surgeries, we tend to do things pretty much the same way. I mentioned my partner, Dr. Clevis. He's a neurosurgeon. I mean, we operate almost identically the same way, despite having very, very different, training. And that's I understand the question. I think that it's just something that has evolved. That both orthopedic spine surgeons and neurosurgeons, I think, do a great job at taking care of patients.
Can you talk to me about the types of questions well-educated patients should ask before deciding on one, to do surgery, and two, who to do the surgery?
Sure. So again, I think either a neurosurgeon or an orthopedic spine surgeon is probably pretty appropriate for patients with spinal deformities. At Ochsner Main Campus, typically we have a collaboration, so multiple surgeons operate on them because it helps. Studies have shown to decrease the surgical time, decrease the blood loss, make the outcomes better. I think patients should ask, basic questions like, what's going to happen to me after surgery? How long am I going to be in the hospital? How bad is my pain going to be? And then what recovery can I expect? It's difficult when someone walks into a physician's office. I think, like you said, it's a hard sell sometimes. And I say, look, we have to do surgery so you don't get worse. Like, that may not make a lot of sense to a patient. That's why patients with myelopathy, you really have to sit down and talk to them, because people Google pinched nerve in the neck, right? And they can get, a pretty clear understanding. But Googling myelopathy and kind of understanding the natural history of it isn't quite as clear. So these patients have to be spent a little bit more time with. And then, I think it's very reasonable. What I tell every single patient is to write their questions down. And if you have a surgery scheduled and you have more questions, call your surgeon and say, hey, can I come in for one more appointment? I just have some more questions. You know, a lot of people will make a phone call to the office and say, can you answer these questions over the phone? I personally like to have a face-to-face discussion when we're talking about what's going to happen with surgery. I think the communication is a lot better than over the phone, and you can look at the x-rays again, you know, you can go over the MRI, you can even re-examine a patient. And to me, that's the most meaningful way to go about it.
All right, here looks like we have one more email question. Doctor, as we wrap things up, doesn't peripheral neuropathy mimic the same symptoms as the one you described for spinal cord compression?
So peripheral neuropathy can be caused by a number of different things. So the most common cause of peripheral neuropathy in the United States is diabetes. On the other hand, people with peripheral neuropathy tend to have more of the pain and burning rather than the neurological dysfunction associated with cervical myelopathy. Now, people who've had chemotherapy certainly can have weakness, can have numbness, can have tingling. But I would tell you that I've seen a lot of patients who are misdiagnosed with peripheral neuropathy, who in fact have cervical myelopathy. And especially if you don't have a condition that's associated with peripheral neuropathy. So you see somebody say, oh, you know, it's just peripheral neuropathy, but nobody takes the time to say, well, wait a second, this patient shouldn't have peripheral neuropathy.
Final question for you, someone who works with the spine. Is there a preferred sleeping way to sleep?
Oh, man.
Head on the pillow, one pillow, two pillows, on your side, on your back?
So there's very little medical literature on this topic, and trust me, I've looked it up. The most I can tell you is, number one, if your mattress is more than 10 years old, it's probably worth buying a new mattress. I sleep on a mattress that is available via mail order for less than $1,000, and you can figure out which that is. There's two main companies, one that starts with a C and one that starts with an L. So I don't think having a super expensive adjustable custom mattress is necessarily the right way, and people will spend a lot of money on a mattress for very understandable reasons, but I think people probably spend too much money.
Gotcha.
Pillows are a tough one. You know, I think whatever pillow is right for you is right for you. But again, I think people, again, tend to spend too much money on pillows. Now, if you buy a pillow and it's terrible, you know, get a different pillow. But it's kind of hard to know. I guess everybody is just so different.
But is the whole head on the pillow? Is it supporting the neck?
I mean,
in your case, my favorite question to ask doctors all the time is, how do you do it?
I like to have, so I sleep on my side, and I like to have a pillow kind of rolled under my neck with my head dangling over it like that. But there are some cultures who sleep on wooden pillows, or I guess wooden head stands.
Right.
In any event, I know what I like, but that isn't to say that there's something that's right for everyone, but I would be cautious about spending a lot of money on it.
All right. Great thing about hosting this program is I get to ask questions when we're done, when he can't tell you things that he can tell me. To make an appointment with any Ochsner physician, including tonight's guest, Dr. Paul Celestre, or register for any of Ochsner's Hello Health seminars, you can call this special number. It's just for viewers of this program like you, 504-842-5669. That's 842-5669. As a reminder, you can rewatch tonight's presentation or most of our Hello Health programs on our website at WLAE.com. Ochsner's website's got lots of them too at ochsner.org. Our thanks again to tonight's guest. He's been terrific. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of this program, Hello Health, and our station, WLAE. Good night.
The enemies we fight against do not slow down. Cancer is relentless. Diabetes is relentless. Time is relentless. So we are relentless. We lose sleep at night dreaming of solutions for wearable technologies, remote monitoring, advancements, innovations, any weapon to win the fight. We are the men and women of Ochsner, and we are relentless. We're doctors and nurses and dreamers and healers, but above all, fighters. Yes, fighters.
Keep working it.
Because when it comes to your health, good is never good enough. So we do not slow down. Ochsner, innovating healthcare.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.